Welcome everyone who's here so far. This is day 3 of our workshop. Nancy will give more details about the whole series in a few minutes, but just a brief introduction. I'm Jim Rosenberger, Director of NIST, and we're hosting this event as part of the Ingram Olkin series. The schedule is showing here, and it's not showing very well, unfortunately. Don't know what's happened with my PowerPoint, but after, oh, that is unfortunate. Let me go out of full screen and see why that happened. You can still see that, I presume. So I will give a brief introduction, and then Nancy will give us an overview, and Jonathan will talk more about the logistics when we get to the breakout. This is the organizing committee. I want to thank them. Nancy will do the same, I'm sure. And a few logistics. Glenn Johnson and Megan Glenn, both NIST participants, are hosting this session along with me. And this is a Zoom session, not a webinar, so everyone will be visible. And so you should be on mute unless you are wanting to speak or are one of the speakers. There is a chat box, and you can ask a question there during the presentations. We'll save question and answers to the end of each presentation if there's time. And let me just mention, every Zoom window does allow you to rename it, and I suggest if it's not your name on that Zoom window to rename yourself. You can do that just by going to participants and go to more, and you have permission to rename. You might even add your institutional acronym after your name. That would be helpful when we get to the discussion phase. And then you would have, that would be your virtual name tag. People will see your name and which organization you're with. So just a few more details. When we're in, you can either be in speaker view or gallery view. And if you're in gallery view while someone's sharing their screen like I am now, you can actually resize that window so you can see more of the participants, or you can just look at the speaker and not be distracted by the others. At the end, we'll send you a link for an evaluation of the session, and we are recording this, so this will be available later for the participants, and at some point we may make this open for the series. And I think with that, Nancy, I will turn this over to you and you can share your slides.
Thanks, Jim. Let me find my share screen button. So I'd like to welcome everybody to this third day of our series on unplanned disruptions for clinical trials. This is a, as you all might imagine, we originally had envisioned this as an in-person meeting, and it follows a, this is part of a series which focuses on trying to bring statistical methodology and data science into new research and public policy collaborations. And it is honoring Ingram Olkin, who was passionate about the field of statistics and also passionate about doing good for society. And so we are putting the two together with the different programs that we offer in these series. So the idea, one of the ideas is to facilitate new collaborations and to identify new research problems, things that are outstanding. So this is where this whole series becomes an experiment being on Zoom, in that there is not time for us to hang out over the coffee bar or the wine after, at the end of the day. And the discussion groups we've tried to pay a fair amount of attention to again engage conversation, because the heart of this this program is the discussion groups. So this is the series. We've had 2 talks from that give perspectives from leaders in government agencies. Today, so we then organized a series of sessions organized around different methodological topics. And the idea is not really to prescribe those as being exclusionary, but we tried to identify topics that are related to the problems one encounters with unplanned clinical trial disruptions. We have several lined up. We had originally, if you saw the original perspective, we'd planned 2 on estimate issues and missing data, and we don't mean, and I say maybe more later here because we may add one. The organizing committee just decided that if we have the second one, it should build on this one rather than just have 2 back-to-back that wouldn't have time to account for the lessons learned here. So that's one of the things that'll come out of the discussion groups, perhaps, is the ideas for follow-on discussions that we should have with respect to this particular issue. And then in a couple of weeks, we're going to, one of the things that came out of the discussions from the statistical leaders in the government agencies was the use of randomization tests. And that has not been popular for a long time. And so we have included that and look forward to everybody getting reacquainted or learning for the first time about randomization tests. And then we'll have topics on adaptive designs, and we are considering another thing that came up in these sessions we had before was the use of external data. So if anybody knows good speakers or can give us some leads on how to put together a session on the use of external data, we would definitely consider doing that. Jonathan's going to talk to you a little bit about the issues and goals for this particular session. We have 3 speakers that I'm very interested in hearing. I will say that before we started organizing this series on unplanned clinical trial disruptions, I had never heard, personally, I'd never heard of Estimands issues, and I find a lot of people in government and other agencies have been working on them in other contexts for some time. So I am really looking forward to getting educated myself in this area. And then, as I say, we're going to go to breakout discussions. I want to thank all of you who answered our questionnaire and talked about, how you would collaborate, how you would like to collaborate with us. And as I say, this is all an experiment. We decided to do something certainly new to us, and that is there is a shared Google Doc which the organizing committee has access to now while the speakers are speaking to take notes, etc. And that doc will be cloned when we go into the breakout rooms to provide seed questions. And so rather than having a recorder, everybody in the breakout room can actually work on the document at the same time. And Jonathan will explain that to you. We're very fortunate to have Toshi Hamasaki and Frank Brentz moderating the breakout room discussions. Toshi is the editor of the Statistics in Biopharmaceutical Research Journal, and Frank is the prior editor. So so this will be great, I know. We'll come back together for a few minutes for reporting and next steps. And the next steps could include, based on your discussions, as I said, additional thoughts for the group that's here getting together, for other groups getting together, for writing. We'd like to have at the minimum, a white paper, perhaps a report on this workshop come out, and Toshi will consider publishing such a thing if it looks worthwhile. I would just say, well, what's the value in that? I mean, you may decide that these are your research problems you've identified and discussed, and you don't want to share them except amongst yourselves. But there is the benefit that I think of to actually putting together a document that gives future directions and needed and identifies things that need to be done, is that you can use it to you can really use it to move the field forward, and individually you can use it for soliciting grant funding, for example, or maybe within your biopharmaceutical environment, you can use it for arguing that things you want to do are important and should have some priority. So you can take such a document, for example, you can reference such a document when you write a grant proposal and say, see, the National Institute of Statistical Sciences thinks this is important, et cetera. So I'm not going to talk more about that now. I'm going to let Jonathan take over, and I know we're all going to have a great time. So I will let Jonathan take the screen now.
Thank you, Nancy. So hopefully everybody can see my screen now. So I'm just going to say a few introductory words about Estimands and missing data, which I'm sure for everybody, or at least most people, is fairly familiar territory. So the idea of a clinical trial estimand is not something new, but it's received a lot of focus in the last few years, and that's culminated in the publication of this ICH E9 Estimand addendum. So the estimand in a clinical trial is what exactly is the treatment effect that you're trying to estimate. And at least according to this addendum, there are 5 components to a clinical trial estimand: the treatments that you're going to compare, the definition of the target population, the endpoint or outcome of interest, what the so-called intercurrent events are and how the analysis will handle these, and the summary measure for the outcome. So for example, will you be looking at the mean outcome or difference in mean outcomes between treatment groups? So these intercurrent events that this addendum talks about, it defines intercurrent events as events occurring after treatment initiation that affect either the interpretation or the existence of the measurements associated with the clinical question of interest. So they're typically things like patients switching from their randomized treatment, or taking additional rescue medications, or dying before you got to measure the outcome of interest, things like that. And the addendum talks about different ways of handling those, so sort of ignoring them in a sort of treatment policy, or what has historically been called an intention to treat type approach, a hypothetical approach where you say, I would like to have something else to have happened rather than what did happen. So for example, preventing patients from switching treatments. Composite outcomes, which include the intercurrent events as part of the outcome in some way, looking at the outcome for as long as the patient remains on their randomized treatment, the while on treatment strategy, and principal stratification. So this came out last year, and with the disruptions, the various different types of disruptions which COVID-19 has caused to clinical trials, I think as the speakers will tell us about in their talks, this Estimand framework could be very useful, but it will in many trials, I think, require some modifications of the Estimand if it was defined in the protocol. So missing data then. So missing data are obviously a ubiquitous issue in clinical trials, and handling missing data always requires some assumptions to be made about the missing data process, whether or not it's explicitly made clear. And some of those assumptions are to some extent untestable. So in clinical trials, my experience has been that missing data are typically handled by either doing a sort of completers analysis, or maximizing the observed data likelihood for a repeated measures type model. So things like mixed models for repeated continuous outcomes. Multiple imputation is increasingly used, and what's common, although sensitivity analyses are increasingly performed, it's typical that primary analyses have historically been done under a missing at random type assumption for the missing data. there's a very close interplay between what estimand you choose and what data are missing for the purposes of the analysis that I think our speakers will talk about later. And COVID-19 will undoubtedly have led to more missing data and different types of missing data than would have been intended at the start of the trial. So just a tiny bit more about the breakout rooms. So there are 2 breakout rooms, and the objectives are to identify and formulate open statistical methodological questions related to the disruptions caused by COVID-19 to trials. And second, to identify and formulate more applied type problems caused by those disruptions. So as Nancy said, there's going to be this document that I'm sharing at the moment, which is a Google Slides document. I'm going to create 2 copies of it just before the breakout rooms open, and each of you in the 2 breakout rooms will have access to collaborate using these slides by making notes. And as Nancy said, I'm not going to talk through these, but there are some initial questions and thoughts here for things that you might discuss in the breakout rooms. Okay, that's me done.
So thank you very much. And our first speaker, David Murray, will share the screen, and I'll say a word or 2 about him while he is doing that. He is Associate Director for Disease Prevention and a Director of the Office of Disease Prevention at the National Institute of Health. He has a passion for prevention research well done and believes that we can best advance the nation's health by ensuring that prevention programs are based on good science, that they're carefully designed and evaluated, effective treatments are disseminated, and effective interventions are identified and discarded. He's involved with a lot of clinical trials that inform the talk he's going to give us now. Thank you, David. And yes, take a half hour.
All right. Thanks very much. I presume that you all can hear me just fine. And I hope that the noise outside is not too troublesome. We got some construction going on in my building. So I'm going to talk about unplanned disruptions in pragmatic clinical trials and draw examples from the Healthcare Systems Collaboratory. I do work at NIH. I'm the Associate Director for Prevention and direct the Office of Disease Prevention. But I want to acknowledge 2 other people that are very important players in the work of the Biostatistics and Design Working Group with the Healthcare Systems Collaboratory. In particular, Patrick Haggerty at the University of Washington and Liz Turner at Duke University. The 3 of us put our heads together a lot in thinking about trying to help the projects that are part of the collaboratory, and certainly they've had input on the material that I'm going to be presenting today. Let's first remind ourselves what pragmatic trials are. Pragmatic and explanatory trials were introduced a long time ago, 1967. Explanatory trials test causal research hypotheses, while pragmatic trials help users choose between options for care. That's the classic definition. I did not grow up with that definition. This was new thinking to me some years ago. I had grown up with efficacy and effectiveness trials out of the Cochrane tradition. Efficacy trials evaluate an intervention under control conditions. Effectiveness trials evaluate an intervention under real-world conditions. So there's a lot of similarity between pragmatic trials and effectiveness trials, though pragmatic trials traditionally are choosing between options for care. Let's talk about some of the designs that are commonly used in pragmatic trials. The first one on the list is the one that you're all extremely familiar with, more familiar with probably than I am, because I don't do many of these. Randomized control trials where we randomize individuals, and those individuals have no interaction with one another after randomization. They don't get any group sessions. They don't have any interaction with one another virtually. They don't have the same therapist or shared interventionist. These are trials in which the classic assumption that errors are independent holds because there's no opportunity for participants to interact with one another. I work with different kinds of trials where that kind of interaction is routine. And the first one that I'll talk about, we call an individually randomized group treatment trial. These are sometimes called partially nested designs or partially clustered designs. Here, it starts out just like an RCT. Individuals are randomized to study conditions. So far, so good. But then what happens is that because of the way that the intervention is delivered, we anticipate that correlation is going to develop among the observations taken from participants who receive the intervention together in a group format, or perhaps have the same therapist or surgeon or other shared interventionist. That could be live, it could be virtual, but there is interaction among participants post-randomization as a result of the way that the intervention is delivered. And that induces a correlation among observations from participants who are in the same, if you will, small group, because they have the same interventionist, or because they met on Tuesday night for their weight loss class, or Saturday afternoon for their smoking cessation class. Individually randomized group treatment trials. These are not nearly as well known as randomized control trials, but they are shockingly common and usually badly analyzed. Parallel group randomized trials. This is the world I live in most of the time. The parallel is an adjective that's been added in recent years with the advent of step wedge designs. So this distinguishes what I've thought of as traditional group randomized trials from step wedge trials. Here we randomize groups, not individuals. And the groups existed usually before we came along. And the members of those groups have been interacted with one another before we appeared, certainly before randomization. They continue to interact with one another during the study. And they'll interact with one another after the study is over and we're all gone. So there is certainly an expectation for positive correlation among observations taken from members of the same group. Here the groups could be hospitals or schools or physicians or communities. I've worked with groups with lots of different characteristics. And then the fourth one that I'll mention is the step wedge design. This is one that has become remarkably popular in the last 5 to 7 years. Here, we're randomly assigning the order in which groups move from providing control observations to providing intervention observations. We anticipate that there is correlation among the members of the same group before the study begins, during the study, after the study. The key distinction between the stepped wedge and the parallel group randomized trial is that all groups start in the control condition and cross over to the intervention condition in a random order and on a staggered schedule. Let's consider the impact on the design. If we have a traditional randomized control trial or randomized clinical trial, there's usually very good opportunity for randomization to take care of confounders because we usually have a very large N. In individually randomized group treatment trials, that's often true, but these studies sometimes are rather small. And if that's true, there may be less opportunity for randomization to do its job. And so confounding may be more of an issue. In the world where I live, parallel group randomized trials, we often have a limited number of groups that we're randomizing. So we may have thousands of people in the study, but if the units of assignment are schools and we have a dozen of them or 20 of them, then I will bet anyone listening that there'll be some difference between the two arms if I've only randomized 20 units. And there'll be some difference on variables that I care about that are related to my outcome. So there is much more limited opportunity for randomization to distribute potential confounders when we have a small number of units of assignment. 10 years ago, the average number of groups in a group randomized trial was perhaps 20 or 25. Currently, it's a good bit larger, pushing 50. So things are getting better, but still, the opportunity for randomization to work is more limited. In a step wedge design, because we observe each group under control conditions and intervention conditions, that takes care of most confounding. We don't have to worry so much, with a very big exception. Intervention effects are confounded with calendar time by design. And that has to be addressed in the analytic plan. And because of that and some other threats, step wedge group randomized trials are inherently less rigorous than the parallel version and should be considered only when a parallel group randomized trial is not appropriate. Impact on the analysis. In a group randomized trial or individually randomized group treatment trial, we've got nested factors. The groups that we've randomized in a group randomized trial are nested within study arms. The small groups or therapists that we're using in an individually randomized group treatment trial are nested within study arms. So we have those nested factors and they need to be modeled as random effects. The variance of any group level statistic will be larger. The degrees of freedom will be more limited. Any analysis that ignores either the extra variation or the limited degrees of freedom is going to have an inflated type 1 error rate. And that inflation can be substantial. It is not hard to have a 50% type 1 error rate in a group randomized trial, even with a small interclass correlation if we have lots of observations in each group. The situation is not quite as bad in an individually randomized group treatment trial, but still important. And extra variation and limited degrees of freedom always reduce power. So we need to deal with these issues during the design of the study. Impact on the analysis for step wedge designs. Well, the crossing of groups reduces the impact of the interclass correlation substantially. And that either will improve the power if we have the same size study or allow us to run a somewhat smaller study. And the magnitude of the improvement depends on the magnitude of the interclass correlation and a number of other factors, but it can be substantial. However, there are other potential sources of bias. As I said, the intervention is confounded with time by design. The intervention effect may vary over time. This is a challenge in a more of a challenge in a step wedge design because I'm gradually losing my control observations as the study goes on. And at the end, I don't have any more control observations. So that varying intervention effect could be important. The intervention effect may vary by group. That's also true in a parallel design. The patterns of correlation may vary over time. That's also true in a parallel design. But in the parallel design, we often have just a pre-post, where in the stepped wedge, we often have multiple observations in each group over time. Any analysis that ignores the sources of bias could be biased. As I noted earlier, the step wedge is at greater risk to the effects of external events. And in the context of the pandemic with COVID, that's something that has raised its ugly head with a couple of the studies that we have that are using step wedge designs. And I mentioned two papers here that I draw to your attention. If you're not terribly familiar with step wedge designs, Carla Hemming has published more on this topic perhaps than anybody. And Fan Lee with Carla and others have a paper coming out in Statistical Methods and Medical Research that's a great introduction to analytic issues in that design. So Jerry Kornfield warned us years ago that randomization by cluster accompanied by an analysis appropriate to randomization by individualism, exercise, and self-deception and should be discouraged. I love the understatement there. He was only talking about group randomized trials, but his comments also apply to individually randomized group treatment trials and to step wedge designs. I am a big fan of Jerry Kornfield and in fact coined the term group randomized trial after his paper from 1978, Randomization by Group. I've talked about 4 designs. How do we choose among them? The first question to consider, is there a strong rationale for randomizing groups rather than individuals? When I was an academic and consulting with lots of people and working with lots of PIs, I would spend about half my time trying to talk people out of a group randomized design. And if I was not successful, I would spend the rest of my time trying to help them do it properly if they were going that direction. So that's an open question. If you can avoid it, do. And if there is no good reason, then you can consider the second question. Do participants receive their treatment in a group format or from a shared interventionist? And that is often the case, not always, but often the case. If not, we have the randomized control trial that you're all very familiar with. If, however, the participants are going to get some of their treatment in a group format or from a shared interventionist, then we have the IRGT trial. If there is a good rationale for randomizing groups, is there a strong rationale for rolling out the intervention to all groups before the end of the trial? If not, we have the parallel group randomized trial. If yes, we have the step wedge design. So this is one way to walk through 3 key questions to help in guiding the selection among these designs. So the RCT is certainly the best comparative design if individual randomization is possible and there's no interaction after randomization. The IRGT is the best if individual randomization is possible, but there's interaction post-randomization. And then we have the group randomized trial that's appropriate when we're trying to evaluate an intervention that manipulates the social or physical environment, or just can't be delivered to individuals without risk of contamination. And that's one of the biggest reasons that people go to group randomized trials. They're worried that patients who see the same physician are gonna interact with one another, or that students in the same school will interact with one another, and that's a well-founded concern in many cases. The step wedge is an alternative to the parallel group randomized trial. Helpful if preliminary evidence makes it unethical to withhold the intervention from any of the groups before the study is over, to if it's impossible to implement the intervention in all groups simultaneously, and I would argue if external events are unlikely to affect the outcomes. So the step wedge is particularly at risk to things like the pandemic. The Healthcare Systems Collaboratory is a project that is supported by the NIH Common Fund, began in 2012, expanded to coordinate pain management collaboratory studies in 2019. So we've got 19 projects now in the collaboratory. You can see at the bottom, we have 2 RCTs, 10 group randomized trials using the parallel design, 5 stepped wedge, and 2 of the most recent studies that are part of the pain management group are using individually randomized group treatment trials. So parallel and step wedge, very common. RCT, not so common. IRGT, not so common. The Biostatistics and Design Working Group is comprised of methods people from NIH, from the Coordinating Center, from each of the participating trials. The working group takes a look at each project during the first part of their UG3 year to consider the design, the analytic plan, the sample size, and to give advice. It's a very cordial and helpful, friendly set of conversations. We're trying to help each team propose as strong an application as possible for the UH3 phase, which comes after the first year. The working group continues to interact with trials funded in that UH3. The COVID pandemic presented itself as an issue earlier this year, and the working group has been interacting with the current trials to help them think through the challenges posed. We're working with sort of 2 frameworks or 2 sets of guidelines in mind. PICO, which I'll talk about a little bit more. PICO stands for Population Intervention Comparator Outcome and Time Frame, and the consort guidelines appropriate for the design. So we're using both of those source frameworks. I'm going to talk about 4 examples, and I'll move to the first one straight away. The Promoting Effective Advanced Care Planning in the Elderly started out as a step wedge group randomized trial. This is a diagram of the original design. We had 36 clinics in this project across 3 sites, planned to recruit about 4,500 cancer patients over age 65. As with most step wedge designs, there's a baseline period where we're collecting data in all the clinics. And then 2 clinics from each site selected at random move into the intervention phase in step 1, 2 more in step 2, 2 more in step 3, and so forth. And by the time we get to step 6, everybody has the intervention. It's the random assignment of clinics to steps or to the sequences here that is critical for the integrity of the design. The intervention here targets physicians and patients, and it's the targeting of physicians that led the investigators and patients, frankly, that led the investigators to decide to randomize clinics. That way, all the physicians and all the patients in the same clinic are in the same arm, and there's lower risk for contamination. The primary outcome is advanced care planning. Did they do it or not? The analysis planned mixed model logistic regression. The COVID pandemic struck during step 2, and all of the clinics increased the work on advanced care planning. Why? Because they're dealing with older cancer patients. So they're at risk. This certainly could affect the primary outcome. It interrupted training for step 2. And after some discussion with the working group, the team decided to adjust their original design, and the revised design is shown here. They couldn't do anything about the first pair of clinics in each site. They're already moving through the process. But they delayed the baseline for the remaining clinics, and they're using the original step 2 as the baseline, and then picking up with step wedge design after that. This allows a test of the intervention before COVID in 6 clinics, after COVID in 30 clinics, and it allows an assessment of the effect of COVID on advanced care planning rates in 30 clinics using the control data from those 30 clinics. Second example I'm going to give you is a study called High-Low. I realize that that name is not terribly descriptive, but I think it'll make sense in a minute. This is a multi-center, open-label, parallel group randomized non-inferiority trial, 120 dialysis facilities with 4,400 patients. So we have 60 dialysis facilities in each arm, 37 patients on average in each facility. They're looking at 2 different phosphate management strategies. One has a higher level than the other, and that's why they call the study High-Low. And the intervention is managed by dietitians at each of the facilities. The outcomes, a composite of mortality and hospitalization. They hadn't quite settled on whether they were going to use a permutation test or a mixed model. The last time I talked to the team, I think they've made that decision now, and I apologize for not having the up-to-date information. The permutation test was attractive because they were uncertain about the distribution of this composite outcome, and certainly a permutation test has advantages there. COVID struck after the intervention had begun in just a few of the sites, but this is a study population at high risk for mortality if patients contract COVID. Facility dietitians were suddenly very busy with lots of other duties. There was concern that high mortality in the 8 sites could complicate the primary outcome or reduce power. They were certainly concerned going forward that transfers from one facility to another could threaten the validity of the design. And they were worried that mortality and hospitalization could vary more than they had planned. So after consultation with the working group, they decided to pause the intervention in the other sites, at least until September. They haven't started up again yet. It's September 1st, so we'll see whether they do this month or they delay a little bit longer. And they're going to add additional facilities to increase power and add a little protection against the threats to power. The third project that I'll talk about is the Guiding Good Choices for Health study. This is a multi-center parallel group randomized trial. They've got 3 healthcare systems involved, 24 pediatricians from each for a total of 72. There are 2 arms, so there will be 36 pediatricians in each arm and about 50 adolescents for each pediatrician. They're going to recruit adolescents who are age 12 who come in to see, or at least scheduled to come in to see, their pediatrician. They're going to do this over 2 years, so there'll be 2 consecutive cohorts of 12-year-olds recruited into the study, about 25 per pediatrician per year. In the intervention arm, the pediatrician recommends the good behavior game to parents by mail or in person when they come in. Staff then offer the parents the group-based or self-guided version of that intervention. Parents who can't be reached or decline the group-based project get the self-guided version. And the group-based intervention sessions are limited to parents who have the same pediatrician to avoid contamination across the units of randomization. The outcomes are measured via telephone surveys annually with youth, and the analysis, again, mixed model logistic regression. COVID struck as the first cohort of adolescents was being recruited. Healthcare systems, as you all know, shifted most non-urgent care to virtual delivery. Families were not very interested in coming in for non-essential in-person visits, and most of the well visits for this population fell into that category. But the healthcare systems have learned that high quality care can be delivered virtually with high patient and provider satisfaction. And the new rules allow billing for telehealth, at least for now. So this particular project is relatively unaffected by the pandemic. The intervention is still being delivered, but it's being delivered virtually. We still have one intervention and two modalities. The group sessions are done by Zoom or similar technology. The self-delivered materials are still sent by mail. So there's a new delivery mode for the group part, Zoom, but otherwise this is moving ahead as originally planned. The investigators are hopeful that this Zoom approach will actually reduce some barriers to access because families don't have to worry about childcare or transportation anymore. Lack of computers or internet could certainly be overcome with mobile phones, and they're doing that where necessary. Early data from the healthcare system suggests that the no-show rates are lower than they had expected, so that's turning out well. The data collection, data analysis plans are unchanged for this study, so this one relatively unaffected by COVID. The last example that I'll give is the pragmatic trial of acupuncture for chronic low back pain in older adults. This is a 3-arm, multi-center, individually randomized group treatment trial. Patients nested either within acupuncturists in the intervention arm or within primary care providers in the comparison arm. We have individual randomization, but the intervention means that patients are seeing an acupuncturist or they're seeing a PCP. And there are 3 arms here that differ based on how much acupuncture there is. And the fact that each acupuncturist sees more than one patient or each PCP sees more than one patient is what makes it an individually randomized group treatment trial. Their outcomes are functional outcomes and pain intensity at 4 time points, with the 6-month value as the primary endpoint. Their analysis plan has been to use repeated measures, GEE, adjustment for baseline, robust sandwich estimators for standard errors. The team expects that each acupuncturist or each PC will only see a few patients. This was a conversation that we had with the group. If they were seeing many patients each, that would be a bigger problem. But the fact that they're only expected to see a few each means that the interclass correlation won't do much damage in this study. When they get to the analysis, they'll perform an omnibus test of any difference among the 3 arms first, and then move to pairwise comparisons if that is significant. COVID struck during their planning year, so they haven't actually started recruitment yet. That's perhaps the best circumstance. It forced them to delay pilot testing. It forced them to delay testing of protocols. So that's a problem, but they will get that done. And it certainly has raised questions about the willingness of patients to visit acupuncturists or PCPs during the pandemic. So what are they doing? Or at least what are they thinking about doing? They're going to raise power. They're going to recruit more people to allow for more attrition. They've delayed recruitment until at least November. They may delay it further. And they're still working through details on the analytic plan. Are they going to address missing data as part of the primary analysis or deal with it in the secondary? They haven't decided. Which covariates are they going to include? They haven't decided. Are they going to model time categorically or as a continuous outcome? And they haven't settled that question either. The general approach that we've taken in the collaboratory is to have each site look at each of the elements in the PICO framework and think about whether COVID might affect it. Is COVID going to change the population that's coming in or that's being recruited? Is it going to change the way the intervention's being delivered? Is it going to change the way that the comparison experience is being delivered? Is it going to change the outcome potentially? And certainly, is it going to change the time frame? So we're asking them to look at each of those elements and think about it. We're also asking them to take a look at the consort guidelines particularly the methods and results section, and think about whether there are elements there that might be impacted. And then to develop a plan, to discuss the plan with the working group, and then to go forward and implement the adaptations needed to preserve the integrity of the trial. I'll close with a few references. Happy to take a couple of questions if there's time, or we can hold questions until later. I'll leave that slide on. Any question?
Thank you, David. Yes. Does anybody? Let's see. I guess. Oh, Sergey. Do you want to talk, Sergey?
Yes. So I'm just working on one study. So a few nursing facilities, like about 40, will be randomized between two groups, and there will be an intervention. So it's like different air filters, which will be changed between like regular filter and advanced filter, maybe every 2 months.
Mm-hmm.
And we will be recording number of COVID cases and the potential confounder number of COVID cases from a previous 2 months period. So what would be advantages and disadvantages of this approach? And we plan to use maybe GE to account for repeated measures within the same nursing facility. And whether if there will be a second wave or a third wave of COVID-19, how it will affect our design.
So it sounds like a group randomized trial, parallel, with perhaps 20 units randomized to each arm. That is a better situation than a step wedge design because you'll have control observations throughout the course of the study. Looking at COVID rates in each of your nursing facilities during a baseline period is a good idea. You can stratify on that potentially if you haven't randomized yet, or if you've already randomized, you could certainly consider it as a covariate in the analysis. The parallel design really is a strength here because you'll be, the expectation is that if you've randomized well, then the experience in the control arm is going to be similar to the experience in the intervention arm in terms of COVID impact. The downside, of course, is that because you're dealing with an elderly population, you may lose people and mortality may be higher than you had expected. That's something that we're dealing with in several of ours. I don't have any magic answers for that. We haven't figured out how to bring people back to life yet. But this is what you've described as a good parallel group randomized trial and ought to do better in the face of some of the problems than some alternatives that I can imagine.
Thank
So
you.
I know that Chris also has a question, but maybe we can save these questions for the discussion groups now.
That'd be fine.
Move on. So keep track of those. So if David will unshare his screen and Mona will take over. While she's taking over, this is Mona Kacha. She is the group head of statistical methodology, the statistical methodology group of Novartis Pharma AG. She's based in Basel, Switzerland. She is engaged in developing and implementing innovative statistical methods for clinical projects covering Estimands discussions and approaches for missing data, longitudinal data, and recurrent event data. So thank you, Mona.
Thank you very much, Nancy. I hope that everyone can hear me well and see the slides. Perfect. So so the title of my talk today is COVID-19 Estimands to the Rescue, and it is following up on a couple of introductory statements that Jonathan has already done, and there are also some similarities to what David talked about, so I will touch upon these throughout the presentation. That said, maybe just to highlight here, so the focus of the presentation will be really on randomized clinical trials. And some of you may be wondering what I mean with Estimands to the rescue of what exactly, right? So essentially what I'm trying to discuss throughout this presentation is that Estimands, and the Estimand framework that was introduced recently in the world of drug development and pharmaceutical statistics can help us in structuring the discussions around the impact of COVID-19 on trial integrity. So something that's very dear to our hearts, right? In terms of the outline of the presentation, I will start with first telling you the outline. So at the beginning, I will briefly discuss trial integrity, what we mean by that, and list some of the complications arising from the pandemic, while David as well as Jonathan have already shared some of these. I will then discuss how a lot of these aspects are very much related to so-called intercurrent events and Estimands, as well as the ICH-E9 addendum, which is a harmonized global guideline for the use in, for the development of pharmaceuticals, let's say, and I will say a bit more about ICH later in the presentation. As I wasn't 100% sure how familiar the audience will be in general with the ICH-E9 addendum, I will first discuss this topic generally for the setting of randomized clinical trials, and then move into more specific discussions pertaining to the COVID-19 impact for Estimands, but also missing data, and then finally draw some conclusions. So in terms of trial integrity, I mean, just very briefly, and we all know this, right? So maybe to start with a smaller bucket with data integrity, and this is defined as the extent to which all trial data are complete, consistent, accurate, trustworthy, and reliable throughout the data lifecycle. I'm pretty sure you're not surprised to hear that COVID-19 is also having an impact on data integrity, but I want to focus on the broader concept of trial integrity, which encompasses data integrity, but also refers to the ability of a trial to produce results which are not affected by unknown biases. And unknown biases can creep in for various reasons, for example, unblinding, or if we have cohort effects on formative dropout mechanisms, which are not adequately accounted for in the assessment of the data. In terms of the impact of loss of trial integrity, right? So the extent to which trial integrity is affected has an impact on the clinical trial interpretability and any conclusions that we can draw from the data collected. And this is, of course, something that all of us now worry about with the COVID-19 pandemic. So to what extent are there any unknown biases, let's say, creeping in that will affect our ability to interpret our clinical trial results at the end? And so the COVID-19 pandemic related complications indeed endanger trial integrity. And throughout this presentation, I want to discuss essentially the potential of the Estimand framework to structure this discussion and to help us maybe have a tailored discussion on the points where we need an alignment across different stakeholders. Now, in terms of the complications, generally, I think it can be helpful to characterize these in two buckets. So on the left-hand side, the complications due to administrative or operational challenges that arise due to the pandemic. And on the right-hand side, the complications which are more directly related to the impact of the pandemic on the health status of a given patient. So on the left-hand side, so the more operational nature, I would count things like treatment discontinuation due to drug supply issues or treatment discontinuation because of a lockdown situation, or because a subject can't, essentially doesn't want to take the drug, or he or she misses a visit because they are not allowed to exit their homes, right? So these are more, you could say, administrative reasons. While on the right-hand side, I'm listing some reasons which are really more directly related to the health status. So for example, if you have COVID-19 symptoms or you contract the virus, then you may have to discontinue the studied treatment. Also, if you have the virus, you may need to take some additional medications. You may die due to the virus. For certain health conditions, for example, if you suffer from depression, it is conceivable that lockdown situations may exacerbate your symptoms. So on the right-hand side, we really have more of these complications, which you could essentially see directly on the health status of the patient, which have a more direct effect. Now, in terms of some characteristics of these complications, I think it is fair to say that for most, if not all of the ongoing studies, the clinical trial teams did not foresee them at the design stage. So I think nobody went into designing a study thinking, okay, so what if a pandemic hits the world? So they are unforeseen, and some of them may indeed be a direct consequence of measures taken because of the pandemic. So for example, if a lockdown situation happens like in various countries here in Europe or in China at the beginning of the pandemic. Now, as David has already said in his presentation, in the case of randomized clinical trials, it is often expected that these complications apply similarly to the different treatment arms. Of course, even in randomized clinical trials, some exceptions may apply. So for example, if you're looking at an open label trial, or if you have a trial that contains immunosuppressive drugs, then you may expect to see some imbalance in the extent of these complications. Generally, the extent will vary across different regions. So different areas of the world are hit harder than others. But the extent will also depend on the attributes of the patients. So for example, elderly patients or those who suffer conditions that have similar disease characteristics as COVID-19 itself are usually at a higher risk of having missing visits or adverse consequences from COVID-19, such as death, for example. In terms of the complicating events, I think also in line with the theme of this day, right? I think they can generally be bucketed again, on the one hand, on missing data. So some complicating events prevent relevant data being collected and therefore result in missing data, while other of these complicating events may not hinder us in actually observing the data. However, they may affect the interpretation of the data, or in some cases, the existence of measurements associated with the clinical question of interest. And this is essentially the definition also that was given by Jonathan. And this refers to so-called intercurrent events, which are discussed in the ICH-E9 addendum. So in the following, I want to spend some time saying a bit more about intercurrent events, about Estimands, and how this translated into the addendum to this ICH guideline, ICH-E9, which if you talk to people working in the pharmaceutical industry, some of them would quote this as being like the holy grail of pharmaceutical statistics, laying out the statistical principles under which we work. So moving to that part of the presentation, so intercurrent events, right? And again, this is just a copy-paste essentially from the previous slide. We mean by that events that occur after randomization, for example, study treatment discontinuation due to various reasons, which affect the interpretation or the existence of measurements associated with the clinical question of interest. Now, to illustrate this, let's consider we have a trial where we are interested in observing various patients from randomization until a certain primary endpoint, and we randomize various patients to different treatment arms. Now, in the ideal case, of course, we would expect that patients are randomized at the beginning, they stay in the study throughout the study, they complete treatment, we get the primary endpoint of interest, so perfect patient in a way from a clinical trial perspective. However, life is, as you know, usually more complicated, and we also, of course, have patients that will not remain in the study or take the treatment throughout the duration of the trial, right? So this is just depicting 3 additional patients who will have certain events that occur after randomization that have some impact on the interpretation, let's say, of their measurements. So patient 2, for example, at a certain point in time, discontinues treatment due to lack of efficacy. Patient 3, at some point, probably also for lack of efficacy reason, decides that he or she needs to take rescue medication. Now, especially with patient 2 and 3, you can imagine that any measurements taken after that point in time where treatment is discontinued or rescue medication is taken, those values, let's say those observations have a different interpretation, right? Like we are usually interested in the measurements on the randomized treatment, you could say, but these treatment discontinuations and rescue medication change somehow the interpretation of the measurements associated with the clinical question of interest. And in the case of patient 4, he or she suffers study discontinuation, which of course leads to missing data. Now, in the case of COVID-19, and I've just depicted this with the additional 3 patients, some of these events that occur after randomizations are directly due to the pandemic. So patient 5, for example, dies due to COVID-19. Patient 6 is not able to take the drug any longer because of drug supply issues caused through the pandemic. And patient 7 suffers from COVID-19 symptoms, or maybe is even infected, and therefore needs to take some additional medication. And all these events, or at least we have to ask ourselves how all these events still enable us to assess any questions that we have in terms of the primary endpoint of interest at the end of the study. And it is really these intercurrent events which are at the heart of the ICH E9 addendum, which was published earlier this year. And so as I said before, the addendum is really attached, let's say, or it's revisiting or revising the ICH E9 guideline, which was published in 1998. This is published by the back then International Conference on Harmonization. For those of you who are not familiar with this initiative, let's say, in the meantime, it was renamed to International Council for Harmonization of Technical Requirements for Pharmaceuticals for Human Use. And it is an initiative that brings together regulatory bodies and pharmaceutical industry across the globe to harmonize regulatory guidance. And this essentially, this ICH E9 was revised, or an addendum was written, which was published last year in November, and it's currently being adopted by major regulatory agencies. So it was already adopted by the EMA in July this year, so it became into effect end of July, and I believe in the US they are still working on that, but it should become into effect soon. So what is an estimand and what is the connection to intercurrent events, right? And I mean, as Jonathan has said, estimands are nothing new in a way, right? So if you look at causal inference literature, or even at books by Rubin and papers, this term has appeared before, but it is in a way somewhat new, or the concept was now more recently introduced to the world of drug development and pharmaceutical statistics. So an estimand essentially represents what is most important to estimate in order to address a scientific question of interest. And this should really be distinguished from the how. So the how is how we estimate the estimand, right? And that's the estimator. And I'm saying that because the revision, or the motivation for the revision of the ICH E9 was mainly triggered by concerns that very often we focus on the how rather than on the what. So for example, even now with the COVID-19 pandemic, you will find very often discussions around how do we deal with the data, how do we deal with the complications and the missing data and so on, but not so much focus is put on the what. So in the presence of the pandemic, what question of interest are we interested in? And I will get back to this a bit. Importantly, the what is sometimes implicitly driven by the how, and I think this is particularly true, or it became particularly apparent in the pharmaceutical industry through the handling of missing data. So very often, certain approaches for missing data handling would be proposed, which would imply a certain scientific question, but the scientific question itself was never really spelled out, nor really aligned with the various stakeholders. And I will give a brief example on this potential misalignment or this ambiguity in the next couple of slides. But before that, just in a nutshell again, the ICH E9 really aims to reassign primacy to the question that we ask, not to the methods by which we answer them. And I think also now in the COVID-19 times, we really shouldn't only focus on methods by which we deal with a problem, but we should always think very carefully, what do these methods imply on the interpretation, let's say, of that estimate that we get? So what is the question we are now answering? And yes, so the framework introduces this, the addendum introduces a framework to better align what and the how. So some of you may think, well, this is trivial, right? I mean, it's trivial. We have to be clear about the what before we focus on the how. And while I agree, I think, and I would be interested in your feedback, in fact, whether this example highlights that what may sound very straightforward is maybe a bit more subtle in certain cases. So I want to use this clinical trial example for illustration. I have a randomized double-blind placebo-controlled phase 3 study. I'm interested in comparing a biologic, drug X, versus placebo in the treatment of an inflammatory disease. And a recognized clinical measure of interest is a continuous symptom score at week 52. So it's really just briefly illustrated here on the left-hand side schematically. And of course, life is not always very simple. So there are some additional considerations for the study that I want to share. So it's not ethical to leave patients, let's say, on placebo, or patients who have some lack of efficacy perception untreated, right? Therefore, the clinical team decides that patients are allowed to switch to rescue therapy, which is essentially drug X itself, because there aren't any other approved treatments for this disease, after week 16 if the symptoms are not controlled. So anytime after week 16, patients are allowed to swap, let's say, to drug X itself. Now, some patient, it is a blinded study, so some patient in drug X as well may perceive a lack of efficacy and therefore have sort of a mock switch to drug X. Not surprisingly, or assuming that drug X really works, many placebo patients are expected to switch to drug X after week 16. There is no deterministic rule for switching to rescue, so it is at the discretion of the investigator or the patient, and patients are followed up beyond switching. Now, the trial objective, a classical trial objective that you would read in clinical trial protocols, would be something along these lines. We want to demonstrate that the efficacy of drug X at week 52 is superior to placebo based on the change from baseline in the continuous symptom score. So far, so good, right? This is a classical objective we would read. Now, the question that I would like to raise here, is this objective precise enough? So let's once more look at a couple of typical trajectories, right? Here I have from randomization to week 52. I have 3 patients on drug, 3 patients on placebo. Again, on both arms, we will have some patients who are taking their treatment and remaining on the trial throughout. However, in drug X, for example, there are some patients that, for example, discontinue their treatment due to lack of efficacy without switching. They just discontinue their treatment. But some actually would like to switch, and they have a mock switch to drug X. While some patients on the placebo arm similarly either discontinue treatment for whatever reason, and some patients also switch to drug X. Now, in this particular case, the switching to the drug is the intercurrent event we see with a lot more frequency. Now, looking back at the objective is to demonstrate superiority at week 52, right? And these events are not really captured in the objectives, right? So as a statistician, let's say, you then start wondering, well, so what exactly should I do now? Like, how should I analyze this data? Should I use the data as I collect it? What do I do with patients that discontinue the study? Generally, I think the main point here is that the objective leaves too much room for ambiguity on the what. And this will hopefully become clear with these examples. So based on the same trial objective, based on the same design, based on the same data, you can ask various questions. And I'm just listing 5 here. Are we, for example, interested in the effect of assigning drug X versus assigning placebo, regardless of treatment switching and treatment discontinuation? This would be like a treatment policy intent to treat question. Alternatively, I could ask a more hypothetical question that gets more, let's say, to the pharmacological effect of the treatment, you could say. I could ask the effect, or I could be interested in the effect of drug X versus placebo if all patients remained on the randomized treatment throughout 52 weeks. Some others may think, well, but the mere fact that patients switch is telling me something about the treatment effect. It's simply not working for the patients. So why don't I look at a composite endpoint where I'm interested in the effect of drug X versus placebo, where patients that switch to rescue or discontinue treatment are considered as treatment failure? Yet another question. Alternatively, again, I could be focusing on the effect of drug X versus placebo while patients did not switch to rescue or discontinue treatment. So this is sort of a while on treatment estimand. Or I could be interested in a subset, let's say, or substrata of principal strata of patients. So the effect in patients that do not switch to rescue or discontinue treatment in either treatment arms, or were they randomized to either treatment arms. So I'm not sort of wanting to discuss the pros and cons and be in favor of one or the other. The main thing I want to make clear here is that the objectives we usually state are very ambiguous and dependent on how we take into account for these intercurrent events, so how we account for them in the description of the scientific question of interest, results in very different, let's say, questions, right? And so once more, a lot of this really boils down to how do we account for events that occur after randomization. We need to be very clear about that, because only if we are very clear about that, we really know what is the estimand, so what is the scientific question we are addressing, and we can remove any ambiguity in that sense so that we can then have an informed discussion on the analysis. It somehow doesn't make sense to discuss a lot around analysis and assumptions and so on if there is still ambiguity in the question, because then we are sort of not targeting the same thing, right? So again, COVID-19 results in numerous unforeseen intercurrent events, as I have depicted here, right? So then the estimand definition itself, as Jonathan has said, is essentially laying out that in order to really precisely specifying the estimand, you need to specify these 5 attributes. There is a thinking process associated with it. So to first think about intercurrent events, to then construct the estimand, and to only then align trial design, data collection, and analyses to that. So now with the COVID-19, not surprisingly, we have some additional intercurrent events, plus we have some missing data. So this whole thinking process is affected, let's say, but it can also help us to structure the discussions. So now with a few minutes left, let's go back to COVID-19 in particular. So how about estimands in view of the pandemic? And this is actually very, or I would say quite related to what David discussed with the PICO framework. So let's look at how the estimand attributes are impacted by the COVID-19 situation. So of course, the population may need to be adapted because you may need to change the inclusion and exclusion criteria to exclude COVID-19 high-risk patients. If that's done, that also has an impact on your estimand. Some trials may need to prohibit certain intake of background medications. Again, that would affect the treatment component. Some trials may decide on changing the endpoint from, let's say, week 52 endpoint to an earlier endpoint, which is not hit hard by the pandemic. But then I think one difference to the PICO framework, which is not spelled out very detailed there, I would say, but again, I would be happy to discuss this later, is these intercurrent events. And I think this is the value of the estimand framework, that it really helps us to structure a discussion around these unforeseen intercurrent events. Now, let's discuss some considerations on intercurrent events. So clearly, every clinical trial team ideally would have already expected, the intercurrent events related to the pandemics were neither foreseen nor addressed at the design stage. I think this is very fair. However, the intercurrent events unrelated to the pandemics were probably already foreseen at the design stage and should therefore ideally be accounted for. Clearly, sometimes when we specify intercurrent events, we do it in a very vague form. So we could say treatment discontinuation due to any reason, While foreseen at the design stage, certainly pandemic-related reasons and the frequency were not anticipated, and therefore a suggestion here would be to really be a bit more precise and to distinguish more clearly between pandemic-related and unrelated intercurrent events. So for example, I would suggest something like treatment discontinuation due to drug supply issues caused by the pandemic should be discussed differently to treatment discontinuation due to lack of efficacy, let's say. Now, in terms of estimate considerations, again, for pandemic unrelated, foreseen intercurrent events, there's likely no need for action. These were already foreseen at the design stage. So I guess it would be, it may even be controversial and need really justification why a team would change anything in that regard. However, in terms of the unforeseen intercurrent events, so for example, intake of COVID-19 medication or death due to COVID-19, we will need to articulate the estimate of interest in respect of these unforeseen intercurrent events. Now, no mention or adaptation of the estimate with respect to the unforeseen intercurrent events implicitly suggests a treatment policy strategy. That is, that we are interested in the effect regardless of these intercurrent events. Certainly, this may be appropriate for certain cases, and especially when you have only very few unforeseen intercurrent events. However, if your study is hit hard by the pandemic, you may want to discuss alternative choices. And these alternative choices may fall into a hypothetical strategy, for example, but also some others could be relevant. And this is something which potentially we could take up in the breakout discussions. So maybe to just share a couple of thoughts on the hypothetical strategies. Essentially, what the hypothetical question could be in this context is, what is the treatment effect in a world where the COVID-19 virus does not exist? Arguably, this could be controversial, especially as the virus is here to stay, you could say. An alternative hypothetical question would be, what is the treatment effect in a world where individuals can suffer from an infection, but where the pandemic-related operational challenges do not occur? I think this makes clear we can ask a number of hypothetical questions. It will really depend which of these is more plausible, will maybe depend on a case-by-case scenario, but I think it also requires some discussion in the scientific community. So are we interested more in treatment policy, where we don't care? So for example, if a lot of patients have drug supply issues and they can't take their drug, we will continue collecting their data regardless and apply a standard ITT type of mindset, or do we want to look more at these hypothetical questions, which you could say are potentially more relevant in a world after the pandemic, hoping that the pandemic will not last forever, right? So I think the relevance and acceptability will depend on various things. I mean, I guess you can think of a cardiovascular outcome trial, for example, where death is an outcome of interest. Well, would you in that specific setting think about a hypothetical estimate where you ask, what if COVID had not happened and this patient had not died? Is this a plausible question? And of course, while I said we have to think about the what first, at some point we have to start thinking about the how as well. And here a question would be, can we reliably estimate a hypothetical outcome? Now, a couple of brief slides on missing data considerations, and again, we can discuss that later in more detail. I think one thing worthwhile highlighting here is that the ICH-9 addendum tries to clearly distinguish between intercurrent events and missing data. The definition of intercurrent events we have already discussed. In contrast, missing data are data that would be meaningful for the analysis of a given estimate, but which were not collected. They should be distinguished from data that does not exist. For example, after a patient dies, the data doesn't exist, or data that are not considered meaningful because of an intercurrent event. And given that the theme of the day is estimates and missing data, I thought I'll just spend 1-2 additional slides on highlighting the difference of intercurrent events and missing data according to the ICH-9 addendum. So let's consider again 3 patients from randomization to a certain time point where we are interested in a primary variable. The intercurrent event that may happen here is treatment discontinuation. And the blue line represents data on treatment, so while a patient was taking his or her randomized treatment. A gray line represents data that is collected, but which is after treatment discontinuation, so which is off treatment, you could say, and no line represents that no data is available at that point. The assumption I want to make here is that treatment discontinuation is not captured in other estimand attributes. So I'm not looking, for example, at a composite estimand where treatment discontinuation is considered a failure. Now, let's assume I would be interested in a treatment policy strategy. In this particular case, treatment discontinuation is an intercurrent event. It will always be an intercurrent event. And patient 1 has no missing data, right? I have the whole information available. Data after treatment discontinuation is still relevant because I'm interested in the effect regardless of treatment discontinuation. So I'm essentially interested in comparing randomizing to, let's say, A versus B. However, patient 2 and 3 have missing data, right? So I have a missing data problem in this specific scenario. Now, in contrast, if I was looking at a hypothetical strategy where I'm asking, had patients not discontinued treatment, here treatment discontinuation is also an intercurrent event. However, and this is now the important difference, patient 1 and 2, strictly speaking at least, have no missing data. Because let's take patient 1, right? I have all the data collected, that blue and gray line. But for the hypothetical question, the gray line, so any data collected after treatment discontinuation, is not relevant for the estimand that I'm interested in. So for the clinical question of interest in the hypothetical strategy, that gray lines will not help me because they are not aligned with my question of interest. So I will need to predict the hypothetical outcome somehow, and very often we will still make use of the missing data terminology for that. But according to the ICH 9, at least strictly speaking, this is not missing data. It is hypothetical data which I need to predict, let's say, while patient 3 has missing data. And again, I'd be quite interested in the views of those on the call, whether this distinction is really useful and valuable. So briefly, and this was already said mostly by Jonathan, so with missing data, it can introduce selection bias. We will have to make assumptions. These assumptions should be aligned with the estimate of interest. Again, we first need to think about the what and then about the how. Then I think with missing data, the way I often think about it is from where or from whom do I borrow information to impute the missing data? And I appreciate that not every method explicitly imputes data. I think at least it helps me to always think of all these methods as somehow implicitly imputing data and borrowing information from somewhere. And are these assumptions plausible and aligned with the estimate? But another question, which I'm not sure how much it is already discussed in the scientific community, is in which cases would we consider not having enough data or information to borrow information from? When would we put our hands up and say, hey guys, we don't have sufficient information to actually do reasonable, robust missing data type of approaches? And then, of course, we need to adequately account for the uncertainty, the added uncertainty, and perform sensitivity analysis. Now, in terms of the prediction, it's very similar in a way, just that the type of assumptions may be different. You may be willing to borrow information from other sources, in my opinion. You may even be interested in borrowing information from external sources to a clinical trial. So coming to the conclusions, with being, I think, a couple of minutes over time. So estimate framework to the rescue with an answer, well, yes, I think it helps to structure the problem and to assess the impact of COVID-19 complications on the trial integrity. And it also helps to distinguish between intercurrent events and missing data, which I think is helpful. But again, I'd be interested in hearing the opinions of others on that. However, the answer is not that simple. So there is a big but as well. I think there would really be, I think there's really need of an alignment on the estimate choice in respect of unforeseen intercurrent events. So are we usually mostly interested in treatment policy, more in a hypothetical? If a hypothetical, which one? When is a composite strategy advisable? So for example, if you have an outcome trial and your patients die, would you really be willing to ignore that effect? In a recent FDA guidance, the removal of affected sites in patients is discussed as an option. And here the question is, this is again talking more from a how perspective, but which estimand is implied by that? And then of course also safety and efficacy. Finally, robust estimation may be challenging and would be nice to discuss that more. And yeah, also of course to do any of these assessments, we require a rich information on the unforeseen intercurrent events. So this is the end of the presentation. Thank you very much for your attention. Here are some references. And also would like to thank quite a few colleagues from Novartis, but also from Rob Hemmings, who one way or another influenced my thoughts on this one.
Thank
so
you.
I will leave this one in. Yeah, thank
That
you.
was terrific. We'll hold questions for the discussion. I hope somebody's cutting and pasting the questions in the chat into the... So Susie Crow is a research fellow at Imperial Clinical Trials Unit in a School of Public Health. She's a member of the Trials Methodology Team and the Clinical Trials Statistics Group. So her statistical research focuses on relevant accessible methods. I'm interested to know what the adjective is, what she's really getting at there. Relevant accessible methods for handling missing data and post-randomization events, such as rescue medication and non-compliance in randomized controlled trials. So, Susie?
Brilliant. Thank you, Nancy, for the introduction and to the NISS for hosting today's event, which has been really thought-provoking so far. So as Nancy says, so I'm going to be outlining a strategy for approaching disruptions in randomized trials because of COVID using missing data methods. So I'm going to start with a brief bit of background and motivating example, which is the ASCOT trial, which is currently ongoing during COVID. I'll then discuss how the ICHE9 Estimands framework and missing data methods can be applied to handle unplanned disruptions. I'll specifically outline 4 steps that can help to ensure the questions of interest are continued to be answered. So this includes clarifying the treatment estimand with respect to the pandemic, establishing what data is missing for the chosen estimand, then specifying primary analysis under the most plausible missing data assumptions, followed by sensitivity analysis. Now, some open questions relating to the choice of the estimand and alternative methods of estimation naturally arise from this, which I'll finish by discussing. Great, so just before kicking off, I'd like to acknowledge colleagues from the MRC CTU at UCL and the London School of Hygiene and Tropical Medicine and Imperial who've worked with me on this strategy. And so this was actually published last month in BMC Medical Research Methodology. So if you would like to see further details following my talk, do look up the full publication, and this is open access. Great, so as we all know, the COVID pandemic has presented a variety of challenges for the conduct and analysis of trials which have overlapped this period. So this has been recognised by the FDA, EMA and MHRA, who've all issued guidance for trialists. Now, subject to participant and investigator safety, which is of course the most important, data collection has been able to continue where possible. And where feasible, remote data capture has been encouraged. But inevitably, as we are all seeing, there will be increased rates of protocol deviations, including missed participant visits, treatment disruptions, and COVID infections. And so this will result in increased rates of missing outcome data and for non-standard reasons in the analysis. Now, secondly, there'll also be participants providing data during COVID where their outcomes have actually been influenced by it. So this potentially impacting the interpretability of the trial. So as an example of an ongoing trial over COVID, I'd like to introduce you to the ASCOT trial. This stands for the Adjunctive Steroid Combination in Ocular Trauma Trial. So here, participants who have suffered traumatic eye injuries requiring open globe surgery in the back of their eye are randomised to receive either just standard surgery alone, or they're allocated to have surgery with an injection of steroid during surgery. Now, it's hypothesised that the steroid injection will improve the healing process in the eye and lead to improved vision at 6 months post-surgery. Now, vision at 6 months is measured using the ETDRS, which measures vision on a scale of 0 to 100. So this stands for the Early Treatment Diabetic Retinopathy Study. And it involves participants reading off a series of letters in decreasing size, probably what you've seen at the opticians, and the number of letters read is the score. So if there's no vision, there'll be a score of 0, and the highest possible score is 100. Now, in the trial, an interim measure of vision is also recorded at 3 months, but the primary endpoint of interest is the ETDRS vision at 6 months. Now on screen is a summary of the Ascot timeline. So recruitment here actually began way back in October 2014, and it was due to finish some time ago, but because it was a lot slower than anticipated, recruitment was actually extended to the end of March 2020. And so with a 6-month follow-up period, the last follow-up was due at the end of September 2020. So fortunately, when the pandemic hit in March, the majority of recruitment had completed for Ascot. So the trial actually hasn't probably been so severely impacted as other trials. But a number of participants, so there was around 10% who were still in the follow-up period when the pandemic hit. Now Ascot's being conducted across multiple sites in England and Scotland. And as just described, it relies on the visual acuity measure taken in clinic with a specific eye chart. Now the trial has remained open during the pandemic for follow-up, but the pandemic and the UK going into full lockdown on March 24th has impacted data collection. So this has included disruptions to standard care and increased loss to follow-up. So there's also the potential that some participants may have been infected with COVID as well. So what implications do these unplanned disruptions have for the trial? So I'm now going to consider what we need to think about differently in the trial analysis relative to pre-pandemic times. So the Estimands framework outlined in the ICH E9 addendum that Mina nicely introduced provides us with a convenient starting point to guide any trial analysis to ensure the questions of interest are answered. So following the establishment of the trial objectives, it's important to precisely define the treatment of Estimands of interest that aligns with that objective. So that is to set out just the precise definition of what you're aiming to estimate. Then the appropriate primary method of estimation can be established and applied to provide that main estimate that answers the trial objective. Now, and since most methods of estimation typically require assumptions, sensitivity estimators can then also be established that also align and estimate the Estimands of interest, but under alternative assumptions to assess the robustness of the primary result. Now, specifically, ICH E9 describes 5 key attributes that together form the description of an Estimand. So, as you've already seen today, these are the population, the treatment condition, the variable or endpoint of interest, how to account for intercurrent events, and the population level summary for the variable. Now, after specifying all 5 in a manner that's appropriate for the trial objective, methods for estimation can then be selected to ensure that trial objective is met. Now, when Ascot initiated, the Estimands framework wasn't formally set out then, because this was back in 2014. But we can think about these attributes now, completely ignoring the pandemic for Ascot to start. And so we've got the population being adults with full thickness open globe ocular trauma undergoing pars plana vitrectomy, so just requiring the eye surgery. The treatment condition is the triamcinolone acetonide, so that's the steroid injection given during surgery. And then the variable of interest, our endpoint of interest, is the ETDRS vision at 6 months. And then with regards to intercurrent events, it was established in the protocol that post-randomization, well, so actually, I should say, in Ascot, patients are actually randomized during surgery. So this is to limit the dropout from surgery, from randomization to surgery. But it was set out that any post-randomization intraoperative events, they would be handled using a treatment policy approach. So essentially, we'd ignore those in the analysis. And then also any subsequent eye procedures, again, would be handled using a treatment policy approach. And then the population level summary for the variable is we're interested in the mean treatment group difference in the ETDRS vision at 6 months. So what additional considerations does COVID bring into play for this trial Estimand here then? Now going forward, as most likely typical, I'm going to assume that the pandemic will not impact the target population, treatment condition, the endpoint and the population level summary of the variable. But of course, there will be many exceptions depending on the disease area, which Mina's alluded to today. But I'm going to assume for now that these are not impacted by the pandemic, as is the case in Ascot. But it's the handling of the intercurrent events that needs to be revisited with respect to new unplanned pandemic-related events, so such as COVID infections, to ensure the child continues to answer the question of interest. So just as a very quick reminder, formally I'm defining here, as in the addendum and others today, an intercurrent event in the context of a randomised trial is defined as a post-randomisation event affecting the interpretation or existence of trial outcomes. So for example, COVID infections or the changing of standard care treatment. And the 5 main strategies presented in the ICHE9 addendum for handling intercurrent events that we can consider are the treatment policy strategy, the hypothetical strategy, the composite variable approach, the while on treatment approach, and then finally the principal stratum approach. Now, when the pandemic introduces unplanned intercurrent events, clarification on how to account for these in the treatment estimand is required. I think considering this first really does help to guide the subsequent analysis approach to ensure the results, hence the interpretations you get from the trial, are appropriate. Now, as acknowledged by the EMA and others, unplanned pandemic-related intercurrent events may directly affect participant outcomes. For example, your direct infection with COVID. But a pandemic might also introduce unplanned intercurrent events that indirectly affect participant outcomes that need to be considered. So here we've got, may have disruptions to standard care or treatments in the trial. And also, for instance, in some trials, redeployment of clinical staff and available resources might impact the standard medical care in the trial relative to pre-pandemic times. And also changes in participant behaviour might also indirectly impact outcomes. Now, going forward, I'm going to focus on 2 estimands that may be of interest in trials overlapping a pandemic that involve handling unplanned pandemic-related events in 2 different ways. So the first estimand is the treatment effect in a hypothetical pandemic-free world. So for this estimand, interest lies in the treatment effect we would have seen had the pandemic not happened. So all impacts of the pandemic, be they direct or indirect, are just a nuisance, and they get in our way of our interpretation of the data. So this estimand therefore uses the hypothetical strategy to deal with the new unplanned intercurrent events. Now, the second estimand that I'll look at is the treatment effect in a world including a pandemic. So here interest lies in the treatment effect that occurs including the presence of the pandemic. So for this estimand, the effects of the pandemic, be they direct through infection or indirectly, are all relevant to the estimand and don't render data collection render the collected outcome data irrelevant. So this estimand uses the treatment policy approach to deal with these new intercurrent events, seeking all data as relevant. Now, clarifying what estimand is of interest is a critical aspect in any trial with new pandemic-related intercurrent events. Now, naturally, the most appropriate estimand will be trial-specific and should be guided by the question of key clinical interest. But I think the value of either estimand will likely depend on the degree to which the trial overlapped with the pandemic and the severity of the pandemic during the overlap period. And also, but probably for many trials, more than one estimand might actually be of interest. So as outlined in ICHE9 addendum, following primary analysis and any associated irrelevant sensitivity analysis, alternative estimands targeting different clinical questions may be explored in supplementary analyses. So these are just targeting a different estimand. Now, after clarifying which estimand is of interest in the analysis at hand, our challenges here now then surround handling the additional unplanned intercurrent events in a way that remains consistent with the chosen estimand. And now, missing data methods provide one tool for doing so. So just to be clear in the following, I'm defining missing data as all data that's required to estimate the estimand of interest, but that are unavailable. So after clarifying the estimand of interest, establishing secondly what data are missing for the chosen estimand can help facilitate the analytical approach required and any assumptions required in this. Now, some unplanned pandemic-related intercurrent events will mean that data is actually physically missing. So that's the data was just simply not collected. But other pandemic-related intercurrent events might mean that some recorded participant outcomes are no longer relevant for the chosen estimand, and so some of the observed data may actually be treated as missing in the analysis. Now, I have put an asterisk on this, as this is not the only way to handle obtained data that isn't relevant for the estimand. So the alternative modelling options may be used, which I'll come back to consider these during the discussion points. But adopting a missing approach now, so for the pandemic-free world estimand, only data that was unaffected by the pandemic is actually required for the analysis. So participant data that are affected by the pandemic may therefore be set missing if it's collected. So whether this be direct or not, directly or indirectly affected by the pandemic. Now for this estimand, there might also be additional missing data from participants whose outcomes were not directly or indirectly clinically impacted by the pandemic, but they're just simply unobserved during pandemic times. And then we might also have data missing from participants whose outcomes were not observed from pre, and hopefully, fingers crossed, eventually the post-pandemic time, which is basically our usual missingness problem. Now for the world including a pandemic estimand, all participant data, so pre, during and potentially post-pandemic, is required for the analysis. Here, any participant data not collected creates a missing data problem that must be addressed in line with the world including a pandemic estimand. I think it's just worth pointing out here that if trial data that are affected by the pandemic are simply included in a standard analysis, the estimated treatment effect will therefore correspond to a world including a pandemic estimand. So once missing data had been established, for the primary analysis, the most appropriate missing data assumptions can then be defined in line with the targeted estimand to perform analysis under. So the three general classes of missing data assumptions are missing completely at random, missing at random, and missing not at random. So in brief, just very quickly, data are missing completely at random when the reason for the missingness is completely unrelated to participants' unobserved outcomes or observed values. So here the distribution of the unobserved data will be no different to that observed. Data are missing at random where missingness does not depend on participants' unobserved outcome values once we've taken into account the information in their observed data in the analysis, such as baseline characteristics. So under MAR, the conditional distribution of the unobserved data will look no different to that of the observed data, but the marginal distribution of unobserved data will vary from that of the observed. And the data are missing not at random when the missingness remains dependent on the unobserved values of the data in some form. Now, the most appropriate missing data assumptions will be estimand and trial specific. Further, especially for the world including a pandemic estimand, different missing data assumptions might also be most appropriate for different participants in the same trial analysis. Therefore, I'm afraid no assumptions can be universally recommended. However, using ASCOT as an example, I will now demonstrate how primary analysis could be approached for each of the pandemic-free world estimand and the world including a pandemic estimand, given the potential different types of missingness we might see. Great, so firstly, to estimate the pandemic-free world estimand, outcome data that are clinically affected by the pandemic, either directly or indirectly, are treated as missing and can be handled in the same way. So for such data, a missing at random assumption, conditional on randomized treatment arm and all observed variables expected to be associated with crucially both the trial outcome and being missing, might be the most reasonable for primary analysis. Now, predictors of both missingness and outcome could include baseline characteristics, such as in ASCOT, you've got your baseline vision, sex, comorbidity, or earlier observed outcome data, including the interim 3-month vision, as long as this isn't affected by the pandemic. Now, such an approach here assumes that the missing outcomes for those affected would have been similar to those of the observed participants who were not affected. So this is enabling the estimation of the pandemic-free world estimand. Now, where follow-up continues during the pandemic, like so in ASCOT, for participants whose trial outcomes were not directly or indirectly affected by the pandemic, but simply lost to follow-up during the pandemic, assuming a missing at random conditional on randomized treatment arm, and all observed variables expected to be associated with both outcome and being lost to follow-up would likely be most reasonable. So for participants lost to follow-up during the non-pandemic times, again, a missing at random assumption may also be most appropriate. But relative to non-pandemic times, there may be different factors expected to be associated with both the outcome being lost to follow-up during pandemic times, with both the outcome and being lost to follow-up during the non-pandemic times. So for example, for ASCOT, age might actually become an important factor associated with both the outcome and loss to follow-up to incorporate in the MAR assumption. So prior to the pandemic, age might not have been associated with both missingness and outcome, only just with the 6-month vision outcome. But due to the pandemic, it might be that older participants may become more likely to stay at home to avoid increased risks of infection. So the data set might actually end up having a higher rate of missing older people during the pandemic. So overall, in summary, for the pandemic-free world Estimand, one carefully thought through enlarged missing at random assumption may be most appropriate for handling all types of missing data in the primary analysis. Now for the world including a pandemic Estimand, outcomes of participants that are affected by the pandemic might actually be quite different to those observable under non-pandemic circumstances, particularly if they're affected directly. So therefore, for participants with missing data who are directly affected by a pandemic, an assumption of missing at random, but importantly including an indicator of being directly infected with COVID, and all other observed data expected to be associated with both trial outcome and being infected, hence the missingness, may be most appropriate. Now, the indicator of infection will ensure that the missing data of infected participants is modelled on the observed data of other infected participants and not the unaffected. But of course, if there are no observed outcome data from directly impacted participants, which will probably be the case in a few scenarios, or if it's actually not anticipated that knowing the COVID infection status will allow adequate modelling of the distribution of the missing outcomes for other infected participants, then a missing not at random assumption may be more appropriate for the data of participants directly impacted. It's perhaps conceivable that probably COVID infection will have a negative impact on the trial outcomes of interest, but really a strong justification will be required to accompany any missing not at random assumption. Now, just as a worst case scenario, one could assume that all infected participants behave like those observed in the trial standard care or the control arm to reflect no treatment benefit, for example, a jump to reference assumption. Or for the infected participants, one could assume a worse outcome than that predicted under MAR by a particular amount. So for example, in ASCOT, if we suppose that COVID infection negatively impacts the vision in a way that's not captured by any observed participant characteristics, we could assume any unobserved infected participant had an outcome that was 20% worse than those for the observed under MAR in their treatment arm. But of course, in other scenarios, it might be the opposite, that COVID infection actually has a positive impact on the trial outcomes, and careful thought will be required. Now, a similar approach could be used to handle missing data from participants who are indirectly affected by the pandemic. So here, in the MAR assumption, it would be important to also include a pandemic time period indicator. So this is to ensure the missing data are modelled based on the data also observed during the pandemic period, rather than pre-pandemic times when the data wasn't affected at all by the pandemic. So where a trial dataset does also include observed data from participants who were directly impacted by the pandemic, and outcome values of those directly and indirectly affected are impacted in different ways, then it may also be relevant to include the infection status within the MAR missing data assumption. But similarly, if there is none or little observed data from indirectly impacted participants, a missing not at random assumption may be more appropriate here. So for participants lost to follow-up during the pandemic time or non-pandemic time, again, a missing not at random assumption may be most suitable. But critically, also including infection status and/or pandemic time period indicator if the dataset also includes observed data from participants who are indirectly or directly infected by the pandemic. So this will ensure the missing data for the non-affected participants is is modelled based upon the observed data of non-affected participants and not the observed data of the clinically affected participants. So just in summary, for the world including a pandemic estimand, again, a carefully constructed enlarged missing at random assumption involving all observed data expected to be related to both missingness and outcome across trial participants, so potentially including the pandemic time period and also participant pandemic infection status, is likely to be the most appropriate starting point for a primary analysis. But in all cases, careful thought really will be required when specifying assumptions to make sure they align with the estimand. Now, after determining the most appropriate assumptions, statistical analysis can then proceed using a method that provides valid inference under the chosen assumptions. So, for example, under missing at random, a complete case analysis or a mixed model for repeated measures, provided the model includes all variables associated with outcome and missingness, would give valid results. Or a multiple imputation analysis, provided the imputation model includes all the variables that are associated with the outcome and the missingness. I think it's worth pointing out that if any post-randomization variables are required to justify the missing at random assumption, say the COVID infection status, as it wouldn't be appropriate to condition on these in the analysis model being post-randomization, incorporating these within a multiple imputation analysis or modelling them as a response in a mixed model would be preferable. Now, under missing not at random, selection models or pattern mixture models may be adopted. And so either can be fitted in a likelihood-based framework or Bayesian framework, or controlled multiple imputation, which combines pattern mixture modelling with multiple imputation, could be used. So controlled multiple imputation means that the analysis exerts direct control over the imputation distribution. So here data is imputed from a specified pattern mixture model multiple times, and then each imputated data set is analysed with the analyst's model of interest, and then results are combined using Rubin's rules. So this is actually, as Nancy was saying earlier, wondering what my relevant accessible methods were. I find controlled multiple imputation a particularly accessible method to use for analysing data under missing not at random. So the pattern mixture model can be formed in numerous ways as is relevant for the trial setting. So here we're just postulating the distribution of the missing data in any which way we might want to. But one accessible option involves estimating and shifting the parameters of the missing at random distribution using a numerical offset term. And this can be used to assess the impact of unobserved participants having a worse or better response than of those observed. So this has been termed delta-based multiple imputation. Alternative reference-based imputation draws imputed values with some reference to the observed data distribution in other groups of the trial, so typically in other treatment arms. Now, a few slides ago, I discussed how different missing data assumptions may sometimes be required for different individuals in the same trial analysis. Now, controlled imputation provides an accessible tool for doing this. Different distributions for the missing data of different groups of individuals. So, for example, missing at random for the loss to follow-up and missing not at random for COVID-infected people can be postulated. And then data imputation can proceed using a number of different imputation models across the trial participants. Now, we've recently published a tutorial in Statistics in Medicine that provides a more detailed practical overview of controlled multiple imputation procedures with worked examples in the Stata code, including where different assumptions are incorporated in one analysis. Now, of course, as any missing data assumptions unverifiable, sensitivity analysis under alternative plausible missing data assumptions should be conducted regardless of the missing data assumption used in primary analysis. And the importance of sensitivity analysis in this context will be higher during COVID as missing data rates increase. Now, sensitivity analysis should critically address the same question, hence the same estimand as the primary analysis. And so as a missing at random assumption is most often likely plausible for primary analysis in the majority of scenarios, sensitivity analysis under missing not at random assumptions will most likely be required. And again, the missing at random distribution might provide a useful departure point for this. Again, using controlled multiple imputation does provide a useful tool for implementing such analysis. So just for the pandemic-free world estimand, in the absence of a pandemic, participants with missing data could have had a worse or better outcome than those observed in the trial. And then for the world, including a pandemic Estimand, depending on the underlying disease, it may also be likely that those affected by the pandemic or those that decided not to attend follow-up visits in person or remotely had a poorer outcome than those observed in the pandemic times. So this missing not at random scenario does become more likely in the context of a pandemic, as a greater number of participants in poorer health would likely stay at home to avoid additional pandemic implications. Also, in other contexts, it might be healthier participants who stay at home since they feel they don't have an essential need for clinical follow-up. So in summary, we found the ICH E9 addendum framework does provide a valuable tool to help understand the impacts of COVID on trial analysis and propose a 4-step strategy for approaching trial analysis with the addition of unplanned COVID disruptions that complements this using missing data methods. So just to finish, of course, there are many open questions surrounding Estimands and the best handling of unplanned disruptions in trials, which I'd just like to summarise. Now, a key factor in any trial will be how to establish which treatment Estimand is of primary interest with respect to the pandemic. And this will require discussions between clinicians and statistical team members. And it will likely depend on the trial progress and the amount of overlap with the pandemic and its impacts. But the value of each of the Estimands I've discussed for different levels of overlap with the pandemic is unclear. So for example, I think it is unclear what degree of overlap renders pandemic-free world Estimand unsuitable. And likewise, the same for the world, including a pandemic Estimand. Also, these aren't the only Estimands that can be formulated with respect to the pandemic and handling of unplanned events. What other Estimands may be of interest remains open. I think Muna mentioned a couple of others earlier. And for example, we also have potentially the treatment effect only during a pandemic as another option there. I focused on handling unplanned disruptions in trials using missing data assumptions and methods. Now, such an approach does require careful thought and justification for missing data assumptions in the analysis. Now, in some scenarios I've outlined, it might be that a missing not at random assumption is most appropriate for certain individuals. For example, those infected by COVID for the world, including a pandemic Estimand, given there was no good data collection. A discussion between clinicians and researchers on the ground interacting with COVID infected participants and statisticians should occur to ensure appropriate, justifiable missing not at random assumptions are chosen. But exactly how to justify a missing not at random assumption and what evidence would be required for this, if most relevant, remains outstanding. And then finally, the adoption of missing data methods to handle unplanned disruptions to target the treatment effect in the pandemic-free world is not the only option. If data collection continues during the pandemic, now, rather than setting any impacted data missing and implying an appropriate missing data assumption, retaining that observed data that's impacted and modelling it using an appropriate causal inference method is an alternative. So, for example, using instrumental variable methods or structural mean models that have been previously applied to handle treatment switching in trials is one option. Now, assumptions will take different forms, and such methods may target slightly different Estimands, which needs careful thought through. I find the missing data approach appealing as assumptions are explicit and therefore accessible, but the potential benefits of alternative approaches are unclear. So the utilisation of other methods for handling unplanned disruptions and the assumptions they require and how to best communicate these, I think does need careful thought. So just to finish, it goes without saying that these are indeed interesting times to be alive in, both generally as a trial statistician. So, thank you.